Okay, we might start. Welcome to the Rapid Fire Retina, Medical Retina Update session. We have 12 speakers for this session. We'll have 5 minutes for the presentation and 2 minutes allocated for discussion and questions. We will try to take the questions after each talk because some of the speakers will be leaving, and we want to have a chance to discuss anything that you might have. So our first speaker is Colin Tan. Colin Tan is from Singapore. He'll be talking on OCT angiography evaluation of macular vasculature.
Okay, thank you for the introduction. Good morning, ladies and gentlemen. Thanks for staying till the last day. I'm glad to see some of us are still here at this meeting. So it's always a great pleasure to present at APAO, and I'd like to thank the organizing committee for this opportunity. So I'll be talking a bit about OCT angiography. These are my financial disclosures, none directly related to this topic. So we are familiar with the foveal avascular zone, or FAZ. This is the central area of the macula that is devoid of capillaries, and traditionally this was measured by fluorescein angiography as shown in this image here, and that has served us well for a long time. However, we also know that there's a great degree of variation in terms of the size and shape of the FAZ, even amongst healthy individuals, and changes in the characteristics of this have been proposed to be either of prognostic or diagnostic value. For example, when there's capillary fallout suggestive of macular ischemia, as shown here. Now, OCT angiography is something that I think more and more of us are using. It's a non-invasive tool that assesses the retinal microvasculature, and one advantage is that it can distinguish between the superficial and deep capillary plexus. So to effectively use OCTA to evaluate FAZ, it's first important to understand variations in healthy individuals before we can compare this with eyes with pathology. So objectives of this study were to determine the size of the superficial and deep FAZ in healthy adults using OCTA, and to ascertain the effects of ocular parameters on FAZ size. This was a prospective study of 170 eyes of healthy volunteers with no history of ocular diseases. The FAZ was independently graded separately by 2 reading center certified graders, and these were then correlated with ocular parameters such as central retinal thickness, axial length, and spherical equivalent. Let's go on to the results. This is the demographics, an equal number of males and females, mean age of 23 years. And this shows the axial length, spherical equivalent, as well as central retinal thickness of this cohort. A bit of a myopia, which is quite common in an Asian cohort. And what we found was that the mean superficial FAZ area was 0.25 square millimeters. But notice the big range from 0.04 to 0.48 square millimeters. So there's a 10 times difference. And the deep FAZ was larger. The mean value was 0.38, but also had a range of 0.12 to 0.66. And just to give you an idea, these are all normal, healthy eyes. And if you look at the top row, that's the superficial deep FAZs of one subject. And you can see the very small FAZs with a correspondingly smaller deep FAZ. The middle row is one with what we term as a medium size, and the last row is that with a large FAZ. So when we analyzed the results, we found that females had larger superficial as well as deep FAZ compared to males. And when we compared the deep versus superficial, it was always significantly larger compared in the deep zone compared to the superficial FAZ. We also found that there was an inverse relationship with retinal thickness for both the superficial and deep FAZs. We went on to do multivariate analysis, and these are the results, but let me just take you through this. We found that for superficial FAZ, the significant factors affecting this was retinal thickness, gender, as well as myopia. And for the deep FAZ, quite similarly, retinal thickness as well as eyeball length, but in this case, age was significant compared to the superficial. So going on to our discussion, These are just a summary of the various factors that we looked at. Other studies have tried to examine various factors. Some have described significant correlation, whereas others have found no significant relationships. We found that the central retinal thickness is significantly correlated with both superficial and deep FAZ, which has been found in at least 2 other papers by Samara and Tick, showing correlations between this and FAZ size. So to conclude, OCTA is useful to image the FAZ. Both superficial and deep FAZs varied significantly in size amongst even healthy adults. The ocular factors such as central retinal thickness and spherical equivalent influence of size and should be accounted for when we assess whether the FAZ appears normal. And studies like these provide important baseline normative data to facilitate comparisons with eyes with pathology, and is crucial for understanding of this technology. Thank you.
Thank you very much, Colin. Do we have any questions from the floor on this paper? Yes.
Nice paper. Just wanted to know if there would be a variability even between the different devices that we use. So we use 2 or 3 devices. We have the Heidelberg, we have the OptoView at our center, we have the Solix, and now I think there's a new from Interlight which takes wide field Octa as well. So does the FAZ, I'm sure you know the background, whether
Yes.
would the FAZ also change, from device to device?
Absolutely. Yeah.
Looking at normative data, so then would that then be applicable across devices? Because I think as a race, we all belong to Asian, so that won't be a problem. But when we are checking across devices, then the normative would not really hold good, wouldn't it?
I agree with you. So I think what's going to happen is, as you mentioned, they differ across the various devices, and obviously part of the reasons will be the different technologies they use, as well as the different segmentation algorithms. So I think going forward, hopefully at some point there will be some kind of unified sort of method that we can allow better comparison. But even for central retinal thickness, for decades we've been comparing different OCT devices, and those are not comparable. So I guess but at least it gives us an idea of the range, and so we at least know that these are factors that affect it, and also the how wide it can be. So I would, in fact, we did do OCTA using other devices on some of these subjects, not all of them, and we definitely found differences.
Great, thank you.
Colin, this is now another element of multimodal imaging,
Yes.
and at least in our country, optometrists are doing more and more imaging of this nature. They're just about to get, I think, onto OCTA. How are we going to educate them on what to see, right? And the second part is there a role, you think, in AI? Now you're creating a normative database that might give you, a percentage risk that you've got a pathological condition.
Yeah, absolutely. So those are great points. I think AI is definitely, as you know, there's so much of it going on, and it's only going to increase from year to year. And definitely, I think AI can help us to perhaps even identify cases that are abnormal outside the range. Because even if I see a small or very small or very large one, how do I know that's abnormal, other than knowing that's within the range? As for the question of optometrists, I think that's very important, because what's important, I feel, is that using our current knowledge, we need to at least let them know that when they look at cases, do not be overly alarmed if you see a very large FAZ. It could still be normal. And if a very small one, I guess, that wouldn't be as alarming, but a large one may be mistaken for ischemia, for example.
Yes, excellent. Anna?
Just one quick comment that actually I think right now, when we look at the OCTs out there, so many brands, the value of OCTA and FAZ imaging is in longitudinal data. So usually you are able to take the same machine for the same patient over and over again. And it's the change that is the matter, and also the comparison between right and left eyes. And I think clinically that is the value at the moment for the OCTA, and not comparing between machines. And I think for optometrists particularly, we need to educate people that if the anatomy is relatively normal and there isn't a lot of segmentation problems, then you can rely on the quantitative analysis. However, if the anatomy is distorted, then you have a problem and you may have to look again.
Yeah.
Thank you. Thank you, Colin.
Right. Thank you.
Our next speaker is talking, this is Ekaterina. Hello, how are you? You're giving a couple of talks back to back. So your first talk is on radiation maculopathy treatment.
Hello everyone. Today we will be discussing radiation maculopathy treatment. efficacy of intravitreal anti-VEGF and steroid implant use. So uveal melanoma is the most common primary intraocular malignancy in adults arising from melanocytes in the uveal tract. Among the various treatment available, radiation therapy has emerged as a highly effective method for the treatment of uveal melanoma, including brachytherapy, proton beam therapy, and stereotactic radiosurgery. Although radiation therapy has a high rate of local tumor control and is a night-preserving treatment, it is associated with radiation macular edema development, which is a significant complication and a common cause of vision loss in patients treated with radiation therapy for uveal melanoma. According to the worldwide literature, anti-VEGF therapy and steroid implant use has shown to delay the progression of vision loss in such patients. But the most effective agents, anti-VEGF therapy or steroid implant, the efficacy and risk factors are not studied in a large randomized trial. So the aim of the study is to evaluate the efficacy of anti-VEGF and steroid implant use in patients with radiation maculopathy after uveal melanoma treatment. Radiation macular edema was present in 180 patients. 123 of them were treated with anti-VEGF and 57 of them with steroid implant. Both groups were statistically homogeneous. The main characteristics of tumor and radiation therapy are shown on the slide. We observed the statistical significant central macular thickness reduction and also visual acuity improvement in both groups. We observed the difference in anti-VEGF and steroid implant efficacy according to period of macular edema development. Up to 6 months, we observed the statistical significant central macular thickness reduction in the group with steroid implant. From 6 to 12 months, we observed the tendency to statistical significance in the group with anti-VEGF therapy. We also observed the factors of anti-VEGF and steroid implant efficacy. As an efficacy, we considered to be the high visual functions. The studied factors you can see on the slide. We observed that paramacular tumor localization and also ellipsoid zone disruption and fluid accumulation in outer nuclear layer have a significant impact on the efficacy of anti-VEGF treatment. In the group with steroid implant, we observed that ellipsoid zone disruption and also diffuse type of macular edema has a significant impact on steroid implant efficacy. In conclusion, macular edema following radiation therapy significantly impacts vision and quality of life. Effective management involves a multidisciplinary approach, utilizing anti-VEGF therapy and steroid implants as primary treatment options. Ongoing monitoring and individualized treatment plans are crucial for optimizing outcomes. Future research is needed to better understand the long-term effects of these therapies and explore new treatment modalities. Thank you.
Thank you very much, Ekterina. I think we can go on. Yep. We'll go on to your next talk and then we can take questions after that.
The next theme I would like to discuss is radiation macular edema risk factors. Returning to the issue of risk factors, we observed that in foreign literature we found the risk factors that is connected with the medical history, tumor characteristics, and therapy characteristics. So the aim of the study is to evaluate the factors of radiation macular edema development in patients with uveal melanoma after brachytherapy. Among 324 patients, radiation macular edema was present in 180 patients. The main characteristics of tumor patients and plaque you can see on the slide. Both groups were statistically homogeneous. We also observed the same characteristics that can be divided in 3 parts. Concerning the medical history, we observed that age under 54 years old has high impact on radiation macular edema development. As to characteristics of tumor, we observed that uveal melanoma height more than 3 millimeters, basal diameter more than 11 millimeters, superior and nasal tumor laterality, paramacular localization of tumor, has higher risk of radiation macular edema development. Concerning treatment characteristics, scleral dose more than 500 gray, dose rate more than 800 centigrade per hour, and plaque diameter more than 15 millimeters have higher risk of radiation macular edema development. Reliable and unreliable factors you can see on the slide. In conclusion, radiation macular edema remains a challenging complication for patients undergoing radiation therapy for ocular tumors. By recognizing the key predictors such as radiation dose, radiated volume, pre-existing conditions, and systemic factors, clinicians can better manage and mitigate the risks associated with this condition. Ongoing research into the mechanisms underlying radiation macular edema will further enhance our understanding and lead to improved management strategies, ultimately preserving vision and quality of life for affected patients. The use of intravitreal anti-VEGF agents and steroid implant has been shown to delay the progression of visual acuity loss, radiation retinopathy, but the optimal timing of therapy, patients most likely to benefit, have not been studied in a large randomized trial. Thank you.
Thank you very much. These are 2 fantastic papers. I'll open it up to the floor now. Any questions from the floor on radiation retinopathy? Well, I have a question.
Yes, please.
I was intrigued by the fact that in the first 6 months, when you were looking at steroids versus anti-VEGF, that you got a better response with the steroid earlier on, and then in the second 6 months, it was anti-VEGF. Do you have a theory why you might have found that result? Is it pathologically, different? Is there maybe inflammation or something earlier on, or then ischemia later?
It seems to us that steroid implant has better efficacy in patients with early complications, as it associated with inflammation because of the irradiated eyes. In the group with anti-VEGF therapy, we expect to see the impact of atrophy and something with neovascularization. So.
Right. Okay. So, did you correlate the macular edema with more peripheral capillary changes, with capillary loss or neovascularization? Was it related?
So, neovascularization was present not in all patients that we treated with the anti-VEGF therapy, but as far as I'm concerned, it is a indication for anti-VEGF therapy. So,
So what do you are a oncologist?
Yes.
Yes. So what do you tell your patients regarding the treatment and other subsequent risk of vision loss?
All of our patients are aware of the complications and consequences of radiation therapy. So they are aware of that vision loss can take place.
Yes. Thank you very much.
Thank you very much.
Thank you. Our next speaker will talk about bilateral optic disc drusen, Srachi. This can be a tricky diagnosis, and you're going to tell us a little bit more about it.
Good morning, everyone. I'm Dr. Shachi Srivastava. I'm Assistant Professor of Ophthalmology at AIOS Medical College, Faridabad. So I'm presenting my case report on bilateral optic nerve bruisings, a misdiagnosed entity. The purpose of the study was to describe the case of a 13-year-old girl with bilateral optic nerve head drusen, which was misdiagnosed and treated for papilledema. This is a case report of a 13-year-old girl who came with a complaint of chronic headache for over a year. She had earlier visited a multi-speciality hospital where on examination, she was found to have a visual acuity of 6/6, both eyes, normal pupillary reflex, and was diagnosed as having grade 3 papilledema. There were no further findings. She was then referred to a neurologist who diagnosed her as having idiopathic intracranial hypertension. She was prior advised MRI with MR venogram, which was grossly normal. She was then started on acetazolamide tablets and steroids and other non-inflammatory medications, but she did not have any relief. She then came to the OPD, ophthalmology OPD of a hospital after 6 months. She was off non-treatment in the meanwhile. On examination, her best-corrected visual acuity was 6/6 partial, both eyes. Left pupil had a slightly sluggish pupillary response. Her color vision was normal. Her fundus examination on direct and indirect ophthalmoscopy and slit lamp biomicroscopic examination was suggestive of pseudopapilledema. Though the disc appeared hyperemic and margins were not clearly defined, however, there was a slight, lumpy, bumpy appearance of the disc, which was more clearly seen on the left side. There were no peripapillary sphincter hemorrhages, and the retinal blood vessels and the vessels at the disc margin were clearly visible. Her perimetry revealed no visual field defect. Based on the suspicious appearance on clinical examination of the optic disc, fundus autofluorescence and OCT was further done. FAF revealed multiple bright hyperfluorescent foci in the disc and revealed all the buried drusen's left more than right. OCT revealed optic nerve drusen as area of irregular hyperreflective core with a uniform internal structure and hyperreflective borders at the surface, thus further confirming the diagnosis. So this is the fundus image of the girl, and as you can see in the left eye, the optic disc margins are not very clearly defined and appear to be slightly raised, but there is a slight lumpy appearance also of the optic disc. This is the fundus autofluorescence of the girl, and it has revealed all the buried drusen, left more than right. This is the optical coherence tomography image of the girl, and as you can see, classically there is a hyperreflective core with hyperreflective border. This is her visual field, and it shows no enlargement of the blind spot or any other field effect. After confirmation of the diagnosis of bilateral optic nerve head drusen, and after neurological reconsultation, the patient was taken off carbonic anhydrase inhibitors and counseled about her condition and is on regular follow-up. The patient currently has no visual problems, and her headache has improved after the course of non-steroidal anti-inflammatory drugs. She has been followed by periodic visual acuity testing, fundus examination, and visual field analysis. Conclusion is that it is very important to have high index of suspicion for the diagnosis of optic disc drusen, as the condition very closely mimics disc edema. Confirmation by various diagnostic imaging like papillary OCT, FAF, ultrasound, etc., help in clinching the diagnosis and can thus change the course of the treatment. One thing I would like to mention is that her intraocular pressure was normal and her CSF tap was also normal. Her CSF opening pressure was also normal. So optic nerve drusen are refractive calcified nodules located within the optic nerve head. They can be mistaken for unilateral or bilateral disc edema, and they can be a source of diagnostic confusion. They may cause visual field defects and may be associated with conditions that cause visual loss, like central retinal artery occlusion and ischemic optic neuropathy. It is very important to appropriately work up and follow this condition to establish a clear diagnosis of optic nerve drusen. Thank you.
can be a real diagnostic dilemma, and a 13-year-old gets put through a whole series of investigations. I might just ask those here, we do see these, and what's the way we generally see them? I've seen these cases when they're referred by optometrists predominantly, but I might just open it up to the audience here. How else do they come to us? Do they ever come to us through neurology?
Just a routine examination.
Routine. So what do you actually say to this child and the parents?
She was actually on acetazolamide since 6 months, and obviously the child was having a lot of discomfort because of that medication, and she was being treated by a very prominent neurologist. So going against the neurologist in the one go was very difficult for me. But yes, I counseled his father. He is actually working at my hospital only. So he had come to show his daughter, and I counseled him that this is just a congenital, some entity, and you do not need to worry about. And she does not need these medications. I consulted the neurologist again, and I explained to him also that this is optic nerve adducent, it is not disc edema. And I told them to follow up with me regularly, and so currently they're as such not having complaint, and their apprehensions have also decreased after proper counseling.
Oh, absolutely. Yeah.
So headache, yes, in a kid, there cannot be any specific cause actually. It might be due to some non-specific cause. She took a course of non-steroidal anti-inflammatory drugs for some time, and after that she had improved. In fact, the neurologist, he also put the DD of vascular headache, migraine or something he was suspecting, but they were not the typical features. But child somehow, after counseling the child, she somehow improved. When I told her you don't have any problem, and we prescribed her some spectacles plus 0.25 diopter sphere, and she's wearing her spectacles, and now she's not having any headache. I think the counseling has done the part.
Yeah.
That's what I'll say.
Thank you very much.
Thank you, sir.
I'll call our next speaker, Anna Tan, and she's going to share with us exciting data on the Balaton and Camino studies for vein occlusions.
Hello. Thank you very much for having me here. So you can see here, I'm here to talk about the Balaton and Camino, and these are the retinal vein occlusion trials with using faricimab and treat and extend dosing. These are my disclosures, as you can see, and the disclosures of the team. So let's go through the study design and the treat and extend regimens. So you can see we had both the Balaton, which was the branch retinal vein occlusion, and the Camino trial, which was the central and hemiretinal vein occlusion trial. And you can see the study design was very similar between those two trials. There was a head-to-head part of the trial where each patient was given monthly doses of either faricimab or aflibercept monthly until week 24. At week 24, both arms were switched to faricimab, and they were then put on a treat and extend dosing regimen all the way until week 72. This is the treat and extend regimen. It is a bit complicated, this slide, but I'll take you through quickly. You can see that first, if the visual acuity was lost for more than 2 lines, then immediately in the bottom right corner, you can see they go back to 4 weeks. Now, when they were able to be extended in the green box, you can see is if they were stable. So there was no change in CST by 10%, either less or more, and their visual acuity remained within the 10 letters. And they were allowed to be then extended. For the rest, if their CST has changed by more than 20%, if they were improving, they were still maintained on their current interval. If they were worsening, but not within the 5-letter gain, they were still maintained. It was more than 5 letters, then their interval was reduced. So you can read more about this study and these interval extensions in that reference below. You can see when you looked at the baseline ocular characteristics between both treatment arms for both Balaton and Camino, they were relatively well balanced in terms of their baseline visual acuity, CST, and the months they were diagnosed with RVO. Now, this is a very important slide, of course. We're always interested about visual acuity gain. And you can see I want to bring your attention to even the first 4 weeks, which means the first injection, you can see the dramatic improvement in visual acuity in both the Balaton and the Commonwealth trial, and this is really well maintained all the way until week 72, even on the treat and extend dosing. And similarly for the CST reductions, you can see even after one injection, a dramatic decrease in CST, and this is maintained throughout the study time of up to 72 weeks, even in the treat and extend portion. And really, when you want to look at the difference anatomically, the nice thing is in this trial we had fluorescein and geography data, and you can see from the first 24 weeks when it was a head-to-head with faricimab and aflibercept, you can see a lot more faricimab patients had the absence of macular leakage after 24 weeks, which is 33% in Balaton and about 44% in Comino. And the great thing really about where we are heading with anti-VEGF now is durability. And this is very important. And you can see in the treat and extend arm, we were able to achieve about 60% of patients getting 12-week or more intervals. And in the Commonwealth trial, more than about 50%. And this is very exciting because it means our patients no longer have to come back for such frequent injections. You can see also for the safety profile, it was relatively well tolerated amongst both the Balaton and the Commonwealth trials with no IOIs that we were all very concerned about with other previous drugs. So I'll just go through quickly my case. This is a case of a branch retinal vein occlusion with macular edema. You can see it's a superior temporal one, lots of macular leakage, and quite a very thick CST of 556. You can see even after one dose of faricimab, dramatic decrease. CST now 342, and the visual acuity increased by 1 line. And as we go on, you can see with after the loading doses, 612 visual acuity, and you can see that we are able to quickly get the patient extended all the way to 16 weeks. There's a slight recurrence at the 16 weeks, but generally the visual acuity remains stable, and we maintain the patient at the 16-week interval. So you can see the patient exited the week after 16 weeks, and they actually never had another dose of faricimab for the 6 months, and the anatomical stability is still very well maintained. Visual acuity is about 612 to 619, and then you can see right here the dramatic improvement and the stability we get even after the patient exited the study. So really the learning points are even after one dose, there's rapid visual and anatomical improvement, and you can get rapid extension intervals very quickly, and they can remain stable with no injections for almost over 6 months, which I've seen the patient now for. Thank you very much.
Thank you very much, Anna. I'll open your talk now to the floor. Any questions? Yep.
Ma'am, my question is that, would you advocate faricimab as the first line of treatment in treatment-naive patients that come to you for the first time? Or would you reserve it for the patients with a resistant macular edema?
So in my practice, in real-world practice, unfortunately in Singapore, we are still a pay system. So in patients where financial issues are not a worry and they're covered by insurance, then yes, my first line of treatment is currently Vabysmo faricimab. However, if financial issues and for our own reimbursement system by the government, they still recommend ranibizumab and Lucentis as first line due to the cost reasons. But if the cost reasons aside, I do think a better drying effect that faricimab has is an excellent reason why it should be first line.
How do you compare it with brolucizumab?
Sorry about that, but in Singapore, brolucizumab has not been approved, so I don't have a lot of experience using Beovu in that case. But I think knowing from the trials the risk of the IOI, it is quite significant, and especially treating retinal vein occlusions already, that is even going to exacerbate the matter. So I think for vein occlusions, even if I had Beovu, I'd be quite conservative about using it, especially now when there's other options like faricimab and Eylea 8 milligrams also. So yeah.
I think the cost is a concern in India also.
Yes.
So we can decide accordingly.
Yes.
Thank you.
Thank you.
Chaitra?
We do know that most of these patients with vein occlusions do have systemic conditions, some recent cardiac event or a neurological event. What would be your choice of an anti-VEGF agent then, if it is not a very recent, say somewhere between 3 to 6 months? Would you still feel okay to give an anti-VEGF injection?
Frankly,
Or-
I usually prefer steroids in that case. So I usually give them a steroid implant for those cases. But I think after the first steroid implant and they get past the 6-month mark, I'm pretty confident that the anti-VEGF safety is reasonable after that.
Okay, thank you.
Thank you.
I have a question for you.
Yes?
You've shown us impressive data about decreased macular leakage when we studied the angiograms. Why do you think that's the case? Is it relating to the Ang2 pathway? Or?
Yeah, I think in terms of when you looked at the biochemical, like the biomarkers and things like that, obviously the Ang2 levels in RVO were exceptionally high. So I think in the and a lot of these RVOs that we took, they were quite acute type of RVOs. So I think in the acute setting, when the Ang2 and the inflammatory markers in general are very high, then you get that dramatic difference in the sort of the appearance and leakage and fluorescein. And I think definitely the dual effect has a role to play in that. I think we need to really do a little bit more specific studies with a bit more, vitreous or aqueous samples to really prove that definitively, but it seems to really be the case, I think, from a lot of inference from a lot of studies before, that probably the macular leakage has the dual effect. The dual effect has an effect on the macular leakage.
Any other questions? I think a comment. In the era of anti-VEGF therapy, the results are so spectacular that the tendency or temptation is to stop treatment.
Yes.
And you can get burned.
Yes.
Would you like to share a little bit about that?
Yeah, so I think it's really interesting when you look at the long-term data of a lot of the RVO cases. Actually, it is about, in the range of CRVO especially, about 30 to 40% need long-term treatment. And I've noticed also that sometimes if you do too aggressive extensions initially, you do get a pretty massive rebound effect. So I would be cautious, and I would actually look at the patient uniquely. Really it's about how much edema, but not only that, it's how much activity they have in the peripheral RVO disease, which is very important. Because if they are there's RVOs that start off really angry, but they resolve really quickly with all the hemorrhages going, and I think those you've been quite confident that the eye will remain stable. But those that still have residual activity, they are very important for you to keep up with their follow-up and treatment. Thank you.
Thank you, Anna.
Thank you.
Our next speaker is Ping Fei. Is Ping Fei here? Not present. Okay. Well, the next speaker is Andrew Chang. Thank you very much for the kind introduction. I'm giving 2 talks, and I'll just do them back to back, and then we can take questions later. Okay, so my first talk is on the RONEX long-term extension trial. It's a 4-year study. We're looking at the outcomes of faricimab in DME. The RONEX, as you know, assess the long-term safety and efficacy of faricimab in DME. It's a phase 3 multi-centre open-label long extension trial. Patients who completed the Yosemite and Rhine trial were then rolled onto RONEX for another 2 years. The study protocol was they attended monthly for the first 16 weeks, and then they were rolled onto a treat and extend protocol up to 16 weeks. They could be extended depending and reduced depending on these criteria. So there were 1,622 patients who completed the Yosemite and Rhine trial, and of these, 1,474 were rolled onto RONEX. So there were 3 groups that rolled into RONEX. The first is patients who were on the faricimab arm every 8 weeks. The second group was the faricimab treat and extend arm, and they just continued on. And the third group, which is an interesting group, are those that were on aflibercept prior to being rolled onto RONEX. Baseline characteristics of these 3 groups were well balanced, particularly their diabetic retinopathy severity status, BCVA and CST. Here we see that the vision gains and the anatomical response which were achieved during the Yosemite and Rhine trials were maintained for another 2 years, with a treat and extend regimen up to 16-week dosing. Because of this, you can see here also that there are fewer injections in years 3 and 4, approximately 7 to 8 in the 3 groups. We are in the modern world, as Anna indicated, aiming for greater durability in an attempt to reduce burden. And at the end of the study, about 80% of patients were extended 12 or greater weeks at the end of that 4 years in all of those 3 groups. Furthermore, if we come to the end of the study at year 4, half of the patients would meet criteria for a potential extension to 20 weeks, and this is very significant for our diabetic patients. If we look at the anatomy here, the absence of DME, which is less than 325 microns, this was achieved in over 90 patients by the end of the study, regardless of the treatment arm. And if we look at the box right at on your right-hand side, the aflibercept group improved from around 82% right up to 95%. If we look at the drying effect, in effect, the first absence of DME, this was achieved 12 to 15 months faster when started on faricimab versus aflibercept. Here's a case that really brings to light what we might see in practice. This is one of the patients from the study. So at baseline, this patient has DME. The vision is 67 letters, CST is 480, and this patient was randomized to the aflibercept arm. You can see he has been having regular injections with, I would say, a good response. So improvement to 72 letters and a reduction of CST to 364. On row next, this patient was rolled on to faricimab. So in a clinical practice, switched to faricimab, and there's continuing improvement with a reduction in CST now to 297. And this is also with 16-week injections. So here we can see sequentially the path of this patient at baseline, at week 100 when the patient was on the aflibercept arm, and then week 200 when they completed the RONEX study. Safety is, of course, a major concern, and faricimab was well tolerated through the 2 years of the RONEX trial. In particular, there were no cases of retinal vasculitis or retinal occlusive events. So in summary, RONEX is the largest DME extension study to date and had excellent patient retention. The vision and anatomic improvements that were observed in Yosemite and Rhine were maintained, with 80% of patients on 12 or longer dosing by the end of the study. And half of the patients at the end of RONEX had the potential to extend out to 20 weeks. There was absence of DME in over 90% of patients, and this drying effect of DME was achieved faster and with fewer injections in the patients who were started on faricimab versus aflibercept. And faricimab is a well-tolerated drug, and in this trial has a safety profile that is continuing to be consistent with the Yosemite and Rhine studies. Thank you. Do we have any, because this is DMA, do we have any questions? Anna.
Thanks, Andrew. I just was wondering, I mean, obviously, right now, this is one of the first few studies that use treat and extend for DME. Previously, we were always looking at DRCRNet and things like that, and that kind of treatment protocol, which wasn't a treat and extend protocol. Have you personally switched patients to treat and extend protocol for DME? Or, and also, when we do that, when do we actually stop treatment?
This is a really innovative way that we now manage patients. Before this study actually recruited, we were already in clinical practice doing a treat and extend. Treat and extend allows you to keep the patients and monitor them whilst titrating the injection frequency to the clinical activity. The other way we were managing patients was a PRN, and to have a patient come in at that interval would be too burdensome, particularly for younger diabetics. And also our clinics weren't able to manage it either, right? Because we wouldn't know if the patients were going to have an injection on that day or not. So we saw, all of us, I think, we were looking at this protocol and we were looking to see, would this work? And it gives us great comfort that it actually does work. When to stop these treatments, that is a question that is highly individualised with each patient. I would say that there are many patients, maybe not many, some patients you can actually stop and continue to monitor. So in my clinical practice, I would go out to 3 months and perhaps 4 months. And if they were dry, I would not treat them. And then I would review them again in 3 or 4 months. And because it's a phasic type of disease. And the results of this study pretty much give support to this as well.
I have a question. Clinical trials are fantastic, doesn't really translate, and especially in a country like India where we have innumerable diabetics with bilateral disease. I'm just going to ask you, do you actually follow a loading dose, number one? And if you do for DME, what's your interval between the second and the third? Do you start extending right away, or do you have a fixed loading dose regimen? Because it's bilateral disease and patients are young. And though you would like to stop treatment, it doesn't really happen.
So in clinical practice, if I have a patient who's got really boggy DME in both eyes and they're already not that compliant to get to that level, what I would do is say that they need treatment in both eyes, but there's an element of trust that needs to be achieved. So I would start with one eye. Then I would ask the patient to come back in a month and actually show them the result. And as we can see, if you're using an anti-VEGF, you're going to see a really strong clinical response. And on that day then, I would probably treat both eyes together. So often we do that. I think in Australia, the majority of retinal specialists treat on the same day. And then I would just try to match that. If one eye is not as bad, then we'll treat just the one eye and continue to monitor at that frequency. So you asked about the load and do we load monthly or longer. I generally would load monthly. And that's what because I have clinical data and our label says that, and it's based on clinical trial data. So I say, look, this is what's prescribed, this is what's approved, this is what we're going to follow. Please do that. If you're asking me now, could we extend out beyond that? Like, there's a good response with the first one. Could you just go out to 2 months and extend right out quickly? The answer is you are very likely to get away with it. But I don't say that up front.
I think you brought up an important point about bilateral simultaneous injections. So we don't tend to do that here as much because we have a lot of patients going back into rural areas, and that's really worrying for us. So we generally never give unless it's a child for ROP under GA or under sedation.
Right.
We don't not as confident giving. What do you do? Do you all do bilateral simultaneous?
We have very low endocrine, but I mean Singapore is a very different place.
It's a cleaner place. The ambient environment is much cleaner. So
your other option would be to do each eye alternately. early on when we were doing anti-VEGFs and we were not confident, that's what we would do. We would do one, like I'm thinking AMD, right? We were actually treating monthly back in the day that we're starting. Then every 2 weeks a patient would have to come in, and that's just too burdensome to do so. But I've got data that might address the patients that need long-term treatment. This is the next talk.
That'll be good to hear.
All right. Can I? Yep. So my next talk, can I have my slides up, please? Yep. My next talk is also on DME, but a more continuous delivery of drug. This is 2-year data from the Pagoda trial, and this is studying the port delivery system with ranibizumab. These are our disclosures. We've touched on and we know that DME is a chronic disease and that many patients continue to require long-term dosing. And we've touched on even in this session that in the real world, vision drops off. And furthermore, in diabetics, there can be a progression to more vision-threatening retinopathy such as PDR. And the protocol T shows us that this occurs in the longer term. So this is the phase 3 Pagoda trial insertion of a port delivery device filled with a special formulation of ranibizumab and Q24 administration for DME. The patients with DME were randomized 3-2 groups. After a loading dose of both groups, at week 16, a PDS implant was inserted and then refilled every 24 weeks. The other group was the IVT PDS group, where they were treated up to week 64 with monthly injections, and then they had insertion of a PDS device and then continued to be filled every 24 weeks. So the primary endpoint was non-inferiority of PDS Q24 week compared with monthly injections of ranibizumab, and this was based on BCVA score from baseline. So this is a patient disposition, and it looks at patients who completed the study through to week 112. And most of the patients who did not complete the study died. So death was the most common reason for not completing. Very good reason. So if we look here that the PDS Q24 arm maintained vision change from baseline through to week 112. You can see in the two groups, if you look at the purple line, that's the PDS arm, and there's a drop around the time of, or immediately post-op of the PDS device at week 16. Once a patient has healed from the surgical insertion of the device, it follows a curve upwards and is entirely stable. And then if you look at week 64, the light blue arm, you'll see there's a similar drop and the patients gradually also improve. So by the end of the study, the BCVA is comparable. Here we are looking at anatomy, and the CST improvement is very stable, and you can see that there's a refill exchange every 24 weeks, and there's no sawtoothing. It's completely steady in the two arms. Here we're looking at DRS score and a two-step improvement, and we can see that the two arms are essentially very similar. At the end of the study, 45 and 43% have improved with a two-step change. Now, there was in the study and in the protocol an option to supplement the treatment if the patients did not were not stable on the PDS. And you can see on your left-hand side the supplemental treatment criteria, a decrease of 15 letters, an increase in CST, or development of high-risk PDR. But what we really were impressed was that the proportion who did not receive supplemental treatment through to the end of the study were over 90%. And this was across both arms. Ocular adverse events here are shown, and if we focus on endophthalmitis, there were 4 cases of endophthalmitis. All the endophthalmitis events were resolved by the clinical cutoff date. The refill exchanges were resumed in all patients, so they were back on track. And 2 patients' vision recovered to baseline or to 20/40, and 1 continued to improve by 12 letters. So these are some clinical images of 1 patient. So it gives you a feeling of what the port delivery device can do. So at baseline in the study eye, we can see here marked macular edema, and there is also edema in the fellow eye. The device gets inserted, and at week 64, the macular edema in the treated eye resolves almost completely, and this continues to the end of the study. Whilst in the fellow eye, it fluctuates, and actually at the end of the study, it is increased. And so this is what we do see in clinical practice. So finally, the PDS with a refill every 24 weeks demonstrate a maintenance of year 1 vision and anatomy gains through the 2nd year. We've seen sustained efficacy. We've seen consistency between patients implanted earlier or later, because they were the 2 arms, 1 at 16 weeks and 1 at 64 weeks. And the risk-benefit profile in DME is favourable over the 2 years. Thank you. Any questions from the floor? Yeah, we were not part of the Pagoda trial. We are now doing the velodrome study for AMD. The device is reproducibly inserted. There are prescriptive criteria for putting it in. I would say that we have patients who have regular injections of Lucentis in their other eye, and they have a port delivery device in the eye that's on the study, and their preference is actually for the device. Yeah, and in the AMD studies, the patients actually did report that their preference was overwhelmingly for the device. The concern is, once the device is in, how long does it last for? And there are devices that have been in the eye for 10 or more years and with no major issues. I think in the early years in which the device was being inserted, there were complications, principally vitreous hemorrhage and extrusion. But these have been really reduced significantly, and you can see here from the Pagoda, so really very low. And that's because surgically there are prescriptive ways to insert it, and the incision size is very prescriptive as well. The conjunctiva is closed really carefully because the conjunctiva closes over it.
Is it painful? How is
no, patients don't even feel it. It's all hidden by the conjunctiva, and it's flat with the globe.
And how do you refill?
Oh, the refill is a really nifty device. Yes. It looks just like a regular injection and a needle, but it has a chamber. So what happens is that the needle is put through the membrane that's under the conjunctiva, and you can generally see it. And as you inject it, it goes in, but also takes out whatever's inside the chamber. So it exchanges in one movement. And so the injection is a bit slower than we would inject. 0.1 mil goes in. You would do it a little bit slower, say over about, you're meant to do it 20 seconds, but I'm generally a bit quicker. No issue. Patients actually don't feel anything at all. So
can you see it on indirect? Is it actually visible?
Oh, yes. Yeah, I should have put a photo here.
Yeah,
I'll show you. It's when you look at it, there's this big device in the eye when you use your ophthalmoscope or use an Optos, and you think the patients will say, the patients don't notice it. It's actually quite peripheral.
No, because when you put in the Ozurdex, they are so distressed. They're like, I can see something. You've left something into my eye. What is it? When is it going to go away?
No, they
So
don't feel
nothing
anything.
happens.
No, they don't feel it.
Have you ever had to remove one?
I've not had to remove, but some devices have been removed earlier on, if it particularly with extrusion. But no, we've had no issues. So in Australia, as part of the velodrome, we're inserting this in now.
Very interesting. I don't think any of us have really.
Yeah, next time we should share with you, or I'll show you some
more
videos.
data, yes,
Yeah,
would be
it's really neat. Yep.
Thank you so much. Wonderful talks.
Okay, so our next speaker is you. Thank you, Chetra. You're going to be talking to us about the Tenaya Lucerne trials for AMD.
Good morning, everyone. Wonderful to be part of this session. And on behalf of all my co-authors, I'm pleased to present the key clinical outcomes with faricimab in the treatment of naive patients with neovascular AMD. I'm going to see how well the real world and the clinical trials correlate, which I think is a big concern for all of us. These are our disclosures. You all know that Tenaya and Lucerne were global phase 3 randomized controlled trials that included 1,329 treatment-naive patients with AMD. Likewise, we have the FAR Retina and the FAR Wide, which are retrospective real-world studies, and FAR Retina basically uses data from the IRIS registry, and FAR Wide uses it from the Medisoft EMR system. One is in the US and one is in the UK. Now, over 2 years, we saw that patients in the faricimab arm achieved disease control with fewer injections compared to aflibercept 8-weekly. And more than 80% of patients on faricimab achieved 12-weekly dosing at the end of the second year. And I think more than 63% lasted for up to 16 weeks, which is very, very important as far as durability of the molecule goes and when affordability is a challenge. These numbers are also important when we are comparing it along with the real world data. Next, let's look at how the post-hoc analysis have shown great anatomical improvements with faricimab in comparison to aflibercept in the initial head-to-head dosing itself. What we saw was a great reduction in the mean CST change from baseline, and a higher proportion of patients actually achieved absence of SRF as well. I think that was really important here. Let me just go to the next slide. Yeah. So what we saw was that the higher proportion of patients actually achieved absence of SRF and intraretinal fluid as well. And what we also saw was there was a reduction in the maximum PD height. This, I think, was a challenge before. We were not seeing drying of the sub-RP fluid. And with these newer molecules, we are able to see much, much lesser fluid even in the below the RP. Now, the next big thing that we want to see is early drying. Everybody is looking for a wow effect. So this was another post-hoc analysis where they saw rapid and persistent resolution of the IRF and SRF from weeks 4 to 12. And this was definitely associated with a better chance of treatment extension in this arm. After the loading phase, patients had resolution were more likely to be extended to 16-weekly dosing versus 8-weekly, and 77% of them were more likely to be on 12-weekly dosing. So this again shows a lot of extended durability for these patients. Let me quickly show you one of my cases here while we transition from clinical trials to real world data. So this is a patient of mine, a 68-year-old female. She presented with decreased vision of 3 weeks duration, diabetic and hypertension well under control, and she was treatment naive. You can see her OCT there. There is subretinal fluid. There is a PED as well. So that was the pre-injection. Now 6 weeks post the first dose of faricimab, you can see what a dramatic reduction there is in the subretinal fluid. You can see the PED is almost disappear. You just see a sliver there. This is, I was following loading dose given that this is neovascular AMD. And this was my second dose. The PED has flattened, and this is, post the third dose, and it's back to normal. So I think what this case basically demonstrates is that we're able to achieve, stability in the disease. We don't really need to keep going back and revisiting. Of course, I followed up this patient, and good for her and me that the disease has not really come back as yet. But of course, she's on a close follow-up. Now, we also want to look at, what was the difference between clinical trials, and are we seeing the same thing in real world? Well, we are looking at what? Outcomes. We are looking at vision. We are looking at anatomical. We are looking at safety. We are looking at efficacy. When you look at anatomical or vision improvement, you can see that it's comparable. Almost all the patients did extremely well. There was good visual acuity improvement. When you also look at anatomical improvements here, you can see that the CST improved rapidly in the Retina and the lucerne, which was also very similar to what you saw in the far retina as well, which were treatment naive cases. Now, coming again to the number of injections that were required, fewer faricimab injections were required in the second 6 months of treatment, and this is also the case in both far retina and far wide, suggesting that treatment extension is a reality. And now coming to safety profile, I think that's just such a big concern for all of us, because we have been seeing IOIs and we are concerned about our patients. Well, faricimab was well tolerated in the Retina and the lucerne, and the rates of endophthalmitis and IOI per injection was very low even in the treatment naive patients of far retina and far wide, as you can see in these numbers. So this presentation basically shows that patients with treatment naive AMD, there are anatomical biomarkers of disease including CST, retinal fluid and PD, all demonstrated great improvement with faricimab compared with aflibercept during the head-to-head Retina and the lucerne. And real world results from far retina and far wide are also consistent with these trials and show vision gains, anatomical improvement and extended durability. And real world safety, as we saw, is very comparable to clinical trial safety. Thank you so much.
Thank you, Chaitra. Do we have any questions from the floor? I do. I have a question.
Yes, please.
You said, I think you showed your case and you did load.
Yes.
But I'll ask you the same question you asked me.
Mm-hmm.
When do you stop treatment? Do you ever stop treatment? And how long do you go, like what's your monitoring length? And Anna can tell us.
So what I do is, especially for neovascular AMD, I do tend to convince the patient to load. And I must say that, a lot of our companies here in India have been generous. They do have patient support programs, which has helped us tremendously. I think especially when most of our patients are not insured and cannot pay out of pocket, these support programs have helped. So loading dose is happening. And I've noticed with neovascular AMD, the minute I do a loading, I'm able to space out injections. I've even been able to stop treatment in a couple of them who responded to the molecule very well. Now, there are few, and we all know they are resistant, they're recalcitrant, they don't respond, which is when I switch. I can't stop treatment because so many of them are literally one-eyed. So I can't really stop. My follow-up initially is at 4 weeks to 6 weeks, not longer than that. But once the disease I know has not recurred, or even if it's recurred, it's just one sliver of, intraretinal fluid here or there, not even subretinal fluid, I do tend to follow up the patient. My counseling is very particular about how they monitor their disease. They have a chart where they will keep looking. The minute they feel a change, they are expected to come back or call us. Because a lot of patients live 200, 300 kilometers away. We are a tertiary care center. They cannot come every week or every month even. So they do monitor, we do monitor them even remotely if required. Yeah.
Excellent. Anna, do you want to answer that and then I'll... I'll give a perspective.
I think
too.
in terms of necessary loading doses, I mean, obviously on one hand, you see that all the visual acuity and anatomical gains in the first 3 injections is very dramatic, and then sort of like the graph tapers off after. But I think increasingly now that we are better with looking at OCT, we can also better predict which patients need the loading and which do not. So I think in smaller lesions, from my experience also type 1 lesions that are not so active, that only just have a little bit of fluid, those actually you maybe be able to start the extension earlier. And whether or not, like I really agree with you, one-eyed patients, I can never stop injecting them. I might even stretch it out to 20 weeks sometimes, but I still keep them on injections long term. But I think for the ones that get stable, they are small lesions, especially the PCBs that have closed, those tend to do very well even when you stop, but you still need surveillance. Thank you.
Yes, absolutely. Thank you.
Thank you very much. Our next speaker is Ikra Khalid. Do we have Ikra here? Not here. Okay. Next speaker is Thilaka. Yeah, thank you. Come on up. You're going to be talking about night vision symptoms and vision in AMD. This is important.
Hi everyone, my name is Dilika Arunachalam. I'm a medical student, research fellow at the National Eye Institute. I also recently am finishing medical school, and I'll be starting my residency in ophthalmology in New York this summer. Today I'll be presenting the association of night vision symptoms and visual acuity in AMD. I have no financial disclosures. So as you all know, AMD is the most common cause of blindness in developed countries, particularly in people over the age of 60. Patients with early or intermediate AMD may have difficulties performing activities under low luminance, like driving or reading at night. The pathophysiology may involve slowing of rod-mediated dark adaptation. Given the interdependence of rods, Is there a reason why I can't see my pointer?
We can. All right. You can't see the pointer.
Yeah, I can't see the pointer.
Just look there and.
Oh, there we go. Sorry about that. I was saying the pathophysiology may involve slowing of rod-mediated dark adaptation. Given the interdependence of rods and cones, rod degeneration may serve as an indicator for impending cone degeneration. So night vision symptoms may indicate an increased risk of progression to advanced AMD. Therefore, assessing night vision symptoms may help identify patients at high risk of disease progression. So the NVQ-10 was designed to measure functional vision under low luminance conditions among people with AMD. It's a brief 10-item questionnaire that asks about driving at night, as well as performing activities under dim light, like reading, adjusting to the dark when entering a theater, and seeing stars in the night sky. So only a few studies have attempted to determine the relationship between NVQ-10 and objective measures of visual function, like best-corrected visual acuity. For example, Wu and colleagues found that NVQ-10 scores were not associated with visual acuity. On the other hand, Ying and colleagues found that poor NVQ-10 scores were associated with an increased risk of a loss of 3 or more lines of visual acuity, as well as the development of advanced AMD. Oh, sorry. And lastly, McGinnis and colleagues found that dark adaptation parameters were negatively associated with NVQ-10 scores and visual acuity. These inconsistencies in the existing literature suggest that the following question remains unanswered. Is there a relationship between NVQ-10 scores and best-corrected visual acuity? So this study was conducted as part of the larger ARIDS-2 clinical trial. This particular data set was collected at the final visit of the larger 5-year study, during which participants completed the NVQ10 questionnaire, and visual acuity was measured using the ETDRS charts. We then performed a multivariable linear regression to understand the relationship between NVQ10 scores and BCVA, using data from the eye with better visual acuity. The model was adjusted for both demographic and clinical covariates, and this analysis was conducted across all participants and also stratified by quartiles of NVQ10 scores. So here's a summary of the demographics and ocular characteristics of our study sample. A total of 1,994 participants completed our questionnaire. Their mean age was 71, and they were predominantly female and white. An older age, gender, education level, smoking history, AMD severity, reticular pseudodrusen, lens opacity, and lens status were all significantly associated with worse visual acuity and were therefore considered as covariates in the multivariable analysis. So among all participants, the NVQ10 composite score was significantly associated with visual acuity. For every 1 unit increase in this score, the visual acuity decreased by 5.1 letters. When analyzed by quartiles, NVQ10 scores were significantly associated with visual acuity only among participants in the last quartile, and these were patients with the worst night vision symptoms. So to summarize, the NVQ10 was significantly associated with visual acuity, but this association was primarily driven by participants in the worst quartile of night vision symptoms. These findings support the concept that subjective visual difficulties, especially in low luminance conditions, precede measurable declines in visual acuity in AMD. Our findings also support the use of patient-reported outcome measures like NVQ10 as valuable adjuncts for counseling patients with AMD and monitoring their disease progression. And lastly, our findings are part of the largest data set of NVQ10 results to date, and therefore support the generalizability of our data. These are my references, and I'd like to thank my mentor, Dr. Chu, as well as my colleagues in the lab and the NEI Intramural Research Program for its funding. Thank you.
Thank you very much, Dalaka.
Sure.
This is very important work. It's work that to date we've presented pivotal data on anatomy, on visual acuity, and we've shown graphs. In all of the AMD studies, the pivotal anti-VEGF studies, there's a VFQ that's always been done, but we never really get to see that data, and we don't really understand it in terms of what we do with our patients every day. We ask questions like, what are you having difficulty with, or they volunteer the fact that they can't read, or they can't drive a car, and increasingly our colleagues in the cataract world are having to hone in on that because they're putting different lenses in, they've got glare at night or flares, and right. But we don't really ever delve into the nuances of functional vision. And obviously your work is based on early AMD, and we are going to face this increasingly with more advanced AMD, that is in dry AMD. But I'd like to get the perspective of our retinal people here. How important is this, and is this actually going to be linked ultimately to a treatment? So we have something called patient-related outcome measure. You've got to prove that there's a functional improvement. So in dry AMD, if we're doing a treatment, there's a slowing of the progression, the payers will say, well, what does that mean, right? And that's why Emily and you are working on this. Anna, would you want to comment on this?
Yeah, I think it's really important that we're shifting more to patient-reported outcomes, and something like that in different situations, it's important. But you know, there's always this resistance by retina doctors to want to do patient-reported outcomes. It takes too much time, so
Yes.
we have to find better tools and the emphasis on it. And I think the new opportunities for the new drugs with GA, now that we can't find any other improvements in visual acuity as a functional measure, we need to find other functional measures. And visual acuity definitely does not tell you the whole picture. One thing I want to also ask, and if you have the data on that, is because a lot of times when these patient-reported outcomes, you take the questionnaire and you try and associate it with visual acuity. For yours, it was great association. But for a lot of other ones, there's poor association. And that's because our visual acuity function measures now are monocular. And people do not use monocular vision when they walk around. They use binocular vision. And we have binocular visual acuity, so that's okay. But we don't have anything more sensitive than binocular visual acuity. So increasingly, when we look for structure-function correlations, I feel that binocular assessments need to be improved, and right now we don't have accurate enough binocular assessments. What do you think? Did you look at binocular visual acuity in this?
We did not, no,
Oh, okay.
we didn't. But I do want to your point, just mention that one of the reasons that we use the NVQ10 for this study was because it only had 10 questions. And so it has a lower response burden compared to like any IVFQ, which has 25 items, or even the low luminance questionnaire, which has 32 items. So this was relatively easier and quicker to finish.
Chaitra?
So now coming to AMD in India, most of our patients who present with neovascular AMD, which is pretty advanced. So at that point of time, we're really not looking at visual quality. We're only looking at restoring ambulatory vision for most of them. And the second chunk of the population that come are illiterate. So for them, the quality of vision really doesn't matter. They just want to be able to resume their activities. A lot of them don't drive. So again, that's a big, a barrier for us to actually check whether their functional activities or is a thing. That's more for DME though. And patients with RVOs, so when you spoke about RVO, a lot of our patients have only macular BRVOs. They have nothing beyond the macula. It's absolutely normal on angiography and everything, but the macula is bad and they recur so frequently. It's really very distressing to see these patients, and they're young. So they are the ones who come with poor quality of vision because they're a younger population, they're working class. There's the challenge that we have the most in our population.
Very, very good points.
Yeah, no, you're absolutely right. I think one of the major limitations of the current questionnaires is that a lot of the questions are about driving, and that doesn't apply to everyone.
Yes.
And there have been a lot of talks about, restructuring the existing VFQs, and I think that's something important to consider for the future.
Comprehensively, we also need to look, apart from just visual function, we need to look at burden of treatment also. And I think that is a very important thing, that patient-reported outcome measures can measure emotional and burden of treatment in part of the question.
Can you have some quantitative tests like B-wave
Yes.
or rod ERG?
Not in the,
Instead
we
of
didn't,
the questionnaire alone for night blindness, any quantitative tests?
Yeah, absolutely. There's like rod intercept time and other.
Low lumens testing.
Oh, yeah, exactly. We didn't do that in these patients, but some of the studies that I mentioned earlier did look at dark adaptation parameters and compared it to visual acuity and the patient-reported outcomes.
Thank you very much, and give our regards to Emily.
Sure, thank you.
Do we have Tariq Ali here? Not here as well. Well, it's been a wonderful session and very interactive. Please go ahead. Charla, let me have a look. I've got here, last talk here is these have been modified. Okay, please. Do you have your slides here? Yeah. Fantastic. It will be a much better session. I was congratulating us on here, but it's still going. Right.
Actually, because of my flight, I have to prepone this thing. So it was a couple of days back. It has been edited and now I've been incorporated in the previous session.
Rajendra, thank you.
So I'll be talking about the early onset and relationship between the age and severity of the diabetic retinopathy. Uh, Diabetic retinopathy is well-known microvascular complication of diabetes, which was considered as the disorder occurring in the middle-aged or elderly patient. Due to the various reasons, rising prevalence of early onset of diabetes, uh, type 2 diabetes in the young population is seen, and so the diabetic retinopathy is also increasing. Our aim of this study was to investigate the various risk factors on the development and progression of the diabetic retinopathy in the young adults. It is a retrospective analysis of the consecutive patient of diabetic retinopathy treated in our center between 2019 and 23. The various data has been collected like age of onset, age of presentation, age of onset of disease, duration of diabetes, and duration of hypertension if it is present, glycosylated hemoglobin, and whatever the treatment is the patient is taking up. Ocular examination include the best corrected visual acuity, anterior segment examination, severity of diabetic retinopathy. Whenever DME was present, it was graded, and what are the treatment modalities. Data was collected at the baseline and follow-up visit at 3, 6, and 12 months, and a plus minus 6 to 8 weeks window was allowed at each visit because it was a retrospective analysis, and the patient who have completed 12 months were included in the data. They were divided into two groups. Group 1 was the age of onset was less than 40 years, and the second group was above 40 years. Total number of patients was 161 in group 1 it was 42, and in group 2 it was 119. The median age was 36 in group 1 and 57 in the group 2. Predominantly it was a male dominant in the both groups. The blood pressure was more in percentage were more in group 1 and 2. Both they are having the systolic blood pressure, but more in group 2. They both having the poor glycemic control, but it was more in and the most of the patient was in group 1 was on insulin, and in group 2 it was 60% was on the oral medications. Age of onset, median age was 25 in younger age group, and in group 2 it was 47%, age was 47. The diabetic grading, most of the patient, almost 53 to 54% of the patient in group 1 had a PDR and PDR with HRC, while DME was more in group 2. Age of onset, we can see that here in PDR and was 30%, and these both PDR and HRC was 53%, and severe were more common in younger age group, while the DME was more in the older age group. 1 year follow-up, most of the few of the patient was increase in all because there was an increase in severity of the disease. So again, PDR was more. PDR was almost same in the percentage wise, but in the after 1 year, but DME was more in group 2. Our observation was concluded that our poor glycemic control common in either group, with the PDR and HRC was more common in the younger age onset group as compared to the older age onset group, and severe DME was more common in the adult onset group. The one possible explanation could be that the people with the young onset of diabetes live with a longer duration with the hyperglycemia and therefore predisposes to the greater risk of the microvascular complications. Our findings were in the lines with the similar with the multicentric study done by Paramasima et al. However, we recorded the little high percentage of the patient with DME in young because our cutoff age of onset was 40 as compared to the 25 in their study. And the Canaan also has shown the incidence of DME was higher in the age of diagnosis after 30 years of compared to the patient diagnosed before the 30 year of the age. A risk factor analysis was concluded in both groups to assess the impact of the age and other variables on the severity of diabetic retinopathy, and elevated systolic blood pressure was also identified as a significant risk factor. Increased blood pressure impact hemodynamics function and VGF-driven pathway in diabetic retinopathy. It upregulate VGF expression in the retinal endothelium and thereby worsen the diabetic retinopathy. The finding in our study demonstrated the risk of developing side-threatening diabetic retinopathy with higher systolic blood pressure, indicate the need to control modifiable risk factors such as hypertension. And it was earlier concluded that by lowering the systolic blood pressure, we can reduce the occurrence of systemic diabetic, side-threatening diabetic retinopathy. To conclude, we find that the PDR and PTR with high risk are more prevalent in the individual with age of onset younger under 40 years, and severe DME was more common in the age of onset above 40 years. Patient with young onset diabetic has a more severe visual loss on the follow-up with 2-line reduction in visual acuity and raised systolic blood pressure, and poor glycemic control increase the risk of side-threatening diabetes. Thank you so much.
Thank you so much. We've got time for just one question. Do we have any questions from the floor? I might just ask you to comment on, in your country, screening for diabetic retinopathy. Yes. This is really, you're looking at the science now and the blinding aspects of retinopathy. How are we going to address this? This is not a public health paper session, but how are we going to manage this?
You see, now I myself is involved in a community health screening, and I'm doing since last about 15-17 years. Earlier, when I started in 2008 doing this screening work. So it was a ophthalmology-based model where I myself was going there and doing the indirect ophthalmoscopy. Later on, we started with the telemedical medicine model, where my optometrist taking the photographs, sending us through WhatsApp or internet, and now recently we have acquired that AI model. We are having a without the financial interest. Remido is a company who is giving the offline AI, inbuilt AI. So last month I have started using that, so I don't.
Excellent, excellent. Chetra?
So I have two practical points to add. Let's take on from the AI model. So in India, we see predominantly peripheral lesions. So none of the current fundus cameras, which are non-mydriatic, are able to get peripheral lesions. So in the OPD, when we dilate and see, most of them have lesions only beyond the mid-periphery, which are blot hemorrhages. And then when you eventually do an angiography, you pick up a couple of microaneurysms. So that's challenge number one. We are not able to do telescreening as effectively. Next, there are two sets of population in India, those who seek medical care and those who cannot seek or do not seek medical care, and who are the chunk of those with diabetes. Now, those are people we cannot access, but even those who are seeking medical care, there is a big resistance by the physicians and the diabetologists to refer patients to a retinologist. They have just kept a 50-degree fundus camera and they do a grading and they say, go away. But patients come to us with very advanced disease, and when you question them, why weren't you referred? They said, we were never told. Yes. At least some of them have a camera, most of them don't even have that. They are open to sending to a nephrologist, but not to a retinologist. Yep. And we are unable to address that concern, which we are doing as Vitro-Retina Society is trying to push an association with diabetologists, but that's yet to happen.
Yeah. One question. We probably need to close soon.
So I would just like to add on, since I'm working in a medical college, a very good coordination is needed between the treating endocrinologist, the physician, and the ophthalmologist, so that the patients, the newly detected diabetics, especially the young patients, they can be referred to the ophthalmologist in time. Even a general ophthalmologist can determine if the patient is having any diabetic retinopathy, and then he can be sent to a retina specialist. So this is something which we should not miss on. The physicians and the endocrinologists should also be aware to refer the patient.
Thank you very much. We'll close the session, but could I ask the speakers to come to the front and we can take a photo? It's the best rapid fire session of the entire Congress.
Thank you. Thank you, sir. Thank you so much.